A patient falls, is stunned for a few seconds, stands up with nothing worse than a headache, and goes home. That ordinary sequence describes the lucid interval, a quiet window that masks one of the most dangerous medical emergencies. As this cross-section of a human skull shows, the patient might feel completely fine while a torn middle meningeal artery is actively filling the narrow space between the bone and the brain. What happens in that space dictates whether the patient lives or dies. We separate the damage into two timelines. Primary injury occurs at the exact instant of impact, when rotational forces stretch and shear nerve tracts. But adding downward vector arrows to our diagram illustrates secondary injury, a delayed flood of low oxygen, low blood pressure, and rising internal compression that starves the brain of blood flow over the following hours. The core physical problem here is the Monro-Kelly doctrine. Because the skull is a rigid, closed box that cannot expand, any new volume introduced into that space, like pooling arterial blood, inevitably crushes the brain. Mortality is driven by this accumulating pressure building in the hours after the patient stands up. To identify that pressure, clinicians rely on specific anatomical signatures. This side-by-side diagram illustrates the two major types of hemorrhage. On the left is an epidural bleed, usually caused by a temporal bone fracture, pooling into a tight biconvex or lens shape because it gets trapped by the tight seams of the skull bones. On the right is a subdural haematoma, caused by torn bridging veins across the brain's surface, spreading into a wide crescent shape, a slower bleed that can show up in elderly patients weeks after a forgotten fall. A skull base fracture creates its own distinct timeline of physical signs. Within minutes or hours, blood can pool behind the eardrums, or manifest as dark bruising around the eyes, raccoon eyes, while bruising behind the ear, known as battle sign, characteristically takes 4 to 8 hours to appear. To track a patient's overall decline, doctors use the Glasgow Coma Scale, scoring eye, verbal, and motor responses out of 15. A score dropping to 8 or below dictates immediate action to insert a breathing tube, because the patient cannot protect their own airway. There is also a critical rule for blood pressure. An isolated head injury rarely causes a state of shock in adults. If a trauma patient has low blood pressure, clinicians must urgently search the chest or abdomen for a bleeding source elsewhere. These signs are vital, but they are ultimately external markers of an internal crisis. Relying entirely on surface symptoms forces clinicians to infer what is happening inside the skull, which is why medicine spent a century trying to find a way to see directly into the box. In 1901, a physician confronting a head injury was entirely blind to internal bleeding. Without imaging or standardized scoring, they desperately needed a physical warning sign that a patient's brain was being crushed from within. The American neurosurgeon Harvey Cushing, building on earlier European research, provided one. By fitting a glass window into an animal's skull and artificially raising the internal pressure with a mercury bag, Cushing recorded exactly how the body's alarm bell rings. Cushing's triad signaled that the brain was already being crushed, but it offered no way to see the bleed earlier. For the next 7 decades, clinicians were limited to tracking pupil changes, reflexes, and inconsistent descriptions of consciousness. Without a shared numerical language, one doctor's stuporous patient was another doctor's semi-comatose one, leaving the true severity of an injury open to interpretation. The first major change arrived in 1971 from outside the medical field entirely. Godfrey Hounsfield, a British electrical engineer working for the music and electronics company EMI, used computer-reconstructed X-rays to generate the first clinical CT scan. He made the exact shape, size, and location of an internal bleed visible without a scalpel. 3 years later, 2 Glasgow neurosurgeons, Graham Teasdale and Brian Jennett, published the Glasgow Coma Scale. They replaced vague medical adjectives with clear, universal, shared numbers that any nurse or junior doctor could accurately repeat at the bedside. Together, these 2 unrelated leaps, one a technological scanner, the other a numerical scale, closed the evidence gap. Doctors could finally measure a patient's deterioration in exact numbers and immediately look at the precise cause. Modern management hinges on these tools. Emergency departments focus on stabilizing the airway, breathing, and circulation, then explicitly preventing secondary brain injury by aggressively controlling intracranial pressure and defending the flow of blood to the brain. This cross-section illustrates exactly what happens when that pressure goes unchecked. In a lethal sequence called transtentorial herniation, the expanding mass pushes brain tissue downward through the tentorial opening, compressing cranial nerves to dilate a pupil and physically crushing the brainstem. As the brainstem compresses, the body triggers Cushing's triad: rising blood pressure, a slowing heart rate, and irregular breathing. The exact physiological alarm bell Cushing recorded in 1901 remains the clearest signal today that death is imminent without emergency surgery. Once CT scanners became a ubiquitous piece of hospital infrastructure, the ability to see inside every patient created a new problem. The temptation to scan every minor bump produced a massive burden of cost and radiation. Medicine solved this overscanning with data. Decades of large-scale epidemiological studies produced validated clinical decision rules, identifying a precise checklist of risk factors. Today, these rules comfortably separate the 1% of patients who need urgent imaging from the 90% who only require clear instructions and reassurance. The score on that chart, the scan already ordered, the vital signs someone is watching right now, all of it exists because it took 100 years to see what that patient walking home couldn't yet feel.